Hello, hello, it's Dr. T here, Wednesday night. How are you, everybody? I don't know about you, but I have had one of those really full days. If you've had a really full day today and you've managed to fill it up to the fullest, then let me know, drop a hi. Thanks so much for jumping on. So many questions through this week. Thank you so much to everybody who has dropped some questions through to us, PM, DM, however you do it. Really appreciate the fact that some of you have been really open and vulnerable about your situation. What I do want to remind everybody is that I try to make the answers to these questions as generic as possible. In fact, when you're asking your questions, try and make them as generic as you can, because it is kind of difficult to answer them when they're really specific. So I've kind of broadened the answers. Remember, everybody's situation is completely different. Hey, Belle Sibley. Everybody's situation is completely different. And so the advice that might apply to one might not actually apply to the other. So just keep in mind, if you have, cool, Georgia, egg retrieval today, whoop, whoop, well done. If you've got specific questions that you want answered, head back to your fertility specialist, your gynecologist, your pediatric gynecologist, your endocrinologist, your GP, and ask those questions until you get the answer that you need. So thank you so much. I know some of you guys are on school holidays. I know some faces on there or some names on there. Thanks so much for joining. Let's get going, shall we? Let's not dilly-dally. All right, someone asked a question about, is there a correlation between the thickness of the endometrium and the amount you bleed when you have your period? What a great question. i.e., a thick endometrium leads to a big bleed and a thin endometrium leads to not much bleeding. Well, would you believe that there is some truth in that? That we know that women who go months without having a period will often slowly develop a really thick endometrium and eventually, I call it a horrenda bleed, but eventually have a reasonably large withdrawal bleed. And in fact, women who do have a very thin endometrium do tend to present with a situation where they might have a little bit of light bleeding for a couple of days, and that's pretty much it. So there is some truth to that. Now, doesn't mean that if you have a normal endometrium, you're going to have a normal bleed. Well, not always, because there are some other things that can lead to having a heavier period. You might have something like adenomyosis, which is the growth of the lining of the womb within the wall of the womb. That can cause problems with the uterus really contracting down, and it can lead to heavier bleeding. You might have fibroids that are impacting on the ability of the muscle of the uterus to contract down. You might have a polyp on the inner aspect of the endometrium, which might lead to heavier bleeding or really funny, strange, prolonged bleeding. So in a lot of cases, they are directly correlated, but there are also very normal appearances, well, not necessarily normal appearances, but normal thickness of an endometrium on an ultrasound that can also lead to heavier bleeding. Someone actually asked a question. I think this is a fabulous question. What is a normal period? That's such a great question. It is normal for a woman to have a regular cycle that goes anywhere from 21 up to around about 35 days. And you can vary within that. And so you might have a cycle that is, 25 days 1 month and 32 days the next, or even up to 35 days the next, and that can be completely normal. That can be classed as a regular cycle. Normally, a woman will bleed for around about 7 days, give or take a day or two. It's probably not normal to be bleeding beyond 10 days. The normal amount of blood loss is around about 80 mils. But I don't know about you ladies, but I don't measure the amount of blood loss on a scale or in a measuring cup. It's very difficult to quantify. And so what we will often call abnormal bleeding is when a woman is her quality of life, her activities of daily living are significantly impacted on. So it might be that she's passing heavy clots and leaking and flooding. It might be that she is having to change pads and tampons hourly. It might be that it's led to significant iron deficiency and fatigue. All of those things can indicate abnormal uterine bleeding. But that's a really awesome question, so thanks for asking that. So ask yourself the question, if your bleeding is significantly interrupting your quality of life, then perhaps go and talk to your doctor about whether or not what you're experiencing is actually deemed as normal. If you're asking the question, in my mind, it's probably not normal. Okay, can I talk a little bit about IUI, intrauterine insemination, as a form of fertility treatment? Okay, so intrauterine insemination is where we take the sperm, we wash it up, we get rid of all the dead ones, we get rid of all the non-sperm cells, and we take that pellet of sperm and we put it inside the uterus. So we're bypassing the cervical mucus. Did you know that up to 90% of sperm can actually get stuck within the cervical mucus, and that is kind of normal? That's why we need well over 15 million motile sperm in order to be considered a fertile sample, because so many of them get lost along the way. So IUI is where you wash it up, spin it down, and take that pellet and you put it up inside the womb, much closer to where conception happens, which actually happens in the tubes. Now, in of itself, intrauterine insemination is probably not a hugely effective form of fertility treatment. So often we combine it with something called superovulation, and that's where we might give a woman a little bit of stimulation, even if she is naturally ovulating, a little bit of stimulation to definitely release one follicle, maybe even two. Those two things combined, superovulation and IUI, will often increase or double your chances of a successfully falling pregnant, if it is done in a population where there is unexplained infertility. So you're already ovulating, you've got proven tubal patency, the sperm itself on a test prep has been proven to be of a fertile sample concentration. If you have all those things in place and nothing else has been found, superovulation and IUI treatment have been found to about double your background chance of conceiving. And in most laboratories, most fertility centres, so though some will differ, it will completely depend on the success rates within your own clinic, but mostly maybe about 15% pregnancy rates. So for many people that come and see me who are deemed infertile, i.e. they've been trying for 12 plus months, regular timed intercourse without success, and they've, not been found to have any obvious fertility problem, probably their background chance of succeeding is way less than 20%, which is the average fecundity each month across all populations. So if your chance of falling pregnant each month is in the order of 5 to 10%, and all I'm doing is doubling your background chance, and I'm probably just bringing you up to what is the normal fertility rate each month. So in of itself, it's not a hugely successful treatment, and that's why some fertility centres choose not to offer it anymore. I certainly think that it is a viable thing to consider in some populations. I wouldn't be doing lots of IUI month after month, because if you're not succeeding, then there's probably something else going on that is not overcomable by simply putting a pellet of sperm closer to where conception actually takes place. The one thing that we definitely haven't been able to check is whether or not the sperm and the egg actually fertilize each other. So that can only be determined in an IVF cycle. So I think that that's probably the best information I can give you about IUI. All right, someone's asked about a blighted ovum. What is a blighted ovum and can you prevent it? Awesome question. I can't stand that term, blighted ovum. If you think it's a terrible term, raise your hand, give me some love, because I think it's an absolutely terrible term. to refer to an anembryonic pregnancy. So it actually refers to, Miss Lizzie, possible first fresh transfer tomorrow, scared with that. Oh, good luck. We give you all our love. Send Miss Lizzie some love, everybody, and give her all the love in the world for possible fresh transfer tomorrow. Good luck, my friend. I hope it works out for you. I really do. Now, blighted ovum. Yes, terrible term. So if you look up the word blight, it actually means decay or something gone bad. It's a really medieval term. So a blighted ovum really refers to an anembryonic pregnancy. What that means is the pregnancy tissue that forms the placenta, the trophoblast, has continued to develop, but the inner cell mass, which makes up the fetus itself, hasn't continued to develop. So you get a gestational sac, but you don't actually get a fetal pole, which is it's heartbreaking. It's a heartbreaking scenario for a woman. So and the most likely cause of an anembryonic pregnancy is aneuploidy, meaning an abnormal chromosome number in the fetus itself. And so it was a pregnancy that was not going to make a baby anyway. Can you prevent it? Not really. It's kind of bad luck. It's unfortunate. I don't know how else to say that than there's nothing really that you can do, that I can do, that can prevent them happening. It's really about making sure that you're seeing a pregnancy that has the normal amount of chromosomes, which is the vast majority. I must say it's the vast majority. So just because you've had one blighted ovum, terrible term, let's call it an anembryonic pregnancy. Just because you've had one anembryonic pregnancy does not mean you're destined to have another. So I hope that helps answer that question. Okay, someone asked a great question about egg maturity. So someone had a situation where less than 50% of their eggs were mature. So how does maturity happen in an IVF cycle? Well, as you may or may not know, we stimulate you to grow up a number of follicles. So we hyperstimulate you, and we use the same drug that your brain produces, FSH, follicle stimulating hormone. We use a synthetic version of that to kind of open the gates and let more follicles actually grow up. So we hyperstimulate you. So we use a higher dose. It's kind of, in my terminology, we kind of put jumper leads on the ovaries to get all of these follicles to grow up. Now, they need to grow to a certain size in order for the next thing to happen. And usually that's above about 14 millimeters in size. Once you get to that stage, ideally sort of 16 millimeters or above, what we give you is something called a trigger. And what that trigger is actually replicating the LH surge that you would normally experience in an ovulatory cycle. And what that LH does is it actually moves the egg along the next stage of development from what we call an M1 to an M2 when the egg ovulates. So it matures the egg, takes it to what we call an M2. Now that is an egg that is then fertilizable. I don't even know if that's a term, but we can fertilize that egg if it's an M2. So you can possibly see where problems might happen that you're not getting mature eggs. And when someone says the eggs aren't mature, it could mean that it's an M1, that it's a little immature, or it could even mean that it's a GV or a germinal vesicle, meaning that that egg that was collected hadn't even gone through the developmental stage. It was still really, really immature. So it really depends on what the others were as to where the problem lies. So either the follicles have not grown up big enough, or an incorrect trigger was given for the type of pathology that you have. There's lots of different types of triggers that you can get given. Or sometimes the follicle quality and therefore the egg quality is not ideal, and so therefore they don't respond to treatment, and therefore they're not mature when when collected. So as you can see, there's lots of different reasons. I'm trying to make this as generic as I can, but what I would suggest is go back to your fertility doctor, because here's the thing about IVF. It can be as diagnostic as it is therapeutic. So a fertility doctor can learn a lot about you and your partner together and how you create embryos, as to them, then they're able to modify any future cycles for you. So we can learn a lot from IVF cycles that then we can tweak and change things. So I would definitely encourage you, if you've had an issue with maturity in the past, to go back and have a chat with your fertility doctor about what things might be able to be tweaked in order to potentially change that in the future. Okay, what else? I think I'll go 2 more questions, okay? There were so many this week. All right, this is one I get asked a lot. Acupuncture. Does it help with egg quality or implantation rates? Okay. Oh, Beck. Oh, bless. Sending you lots of love, my friend. Yeah, where was I? Acupuncture. Okay, acupuncture. Unfortunately, there has been fortunately, however you see it, there's been a large multi-center randomized controlled trial, so well-organized study that has looked at the impact of acupuncture on implantation and pregnancy rates. And the study was stopped because it did not show any improvement when comparing it to sham acupuncture. So that was a bit devastating for so many people who swear by acupuncture. There are probably a lot of difficulties, I believe, in studying acupuncture. Maybe sham acupuncture itself actually had an impact. Maybe the wide variety of acupuncture practitioners impacted on the results, because obviously it was in lots of different centers. Maybe the patient choice was, the variables might have been too wide. So I think a very difficult study to do. Does it cause harm? Well, we've shown that it doesn't cause harm. Could it potentially help a patient to manage the treatment burden? Definitely. I have so many patients who utilize acupuncture throughout their treatment, not specifically for the embryo transfer, but throughout their treatment, and swear by it. So would I ever discourage a patient from using acupuncture? Probably not, because I do believe that it may have some benefit, particularly in helping with treatment burden, but I cannot put my hand on my heart and say, yeah, it helps improve egg quality or implantation rates, because the evidence just is not there for that. Okay. All right. Now, I've had loads and loads of questions, and very patient-specific questions about adjuvants included in treatment. So additional supplements included in fertility treatment. So I'm going to be as generic and widespread as I can on this, because people have asked about myoinositol, they've asked about CoQ10, melatonin, DHEA, testosterone, growth hormone. I can tell you that there's a very good quality study to show that growth hormone does not help improve egg quality. But as for the rest of them, again, there is no good quality evidence to show that all of those other things impact on egg quality, because that's the context in which most people are using these, is to improve the quality of the egg as it's developing in its follicle to then be released and fertilized, and obviously create a good quality embryo, which goes all the way through to pregnancy and a live birth. But again, a really difficult area to study, because we're dealing with a small group of women. They tend to be older women who are taking these to help improve egg quality. So there's not a lot of really good quality research in this area. I probably wouldn't encourage the use of growth hormone. I think that there's enough side effects with growth hormone. It's exorbitantly expensive in Australia. And I think that there is a reasonable quality evidence to say that it doesn't work. But as for things like coenzyme Q10, coenzyme Q10 is an enzyme that is part of the electron transport chain. We know it helps to, the theory is that it helps to improve mitochondrial health, and we need the mitochondria to help the internal functioning of the egg actually work. It's not all about the genes. And so there's the possibility that it might be beneficial. There's some lower quality studies that have suggested that it might actually help. Same goes with melatonin being used as a powerful antioxidant. Was actually discovered because a whole heap of women were taking it because they were trying to sleep because they were having great stress and anxiety through their IVF treatment. And so DHEAS the same. A lot of women, it was actually first utilized in New York, and it was because a lot of women were seeking DHEA through their naturopaths. So I think that, there's not great quality evidence on this stuff. Could it be beneficial? Maybe. Is it particularly harmful? Probably not. Testosterone, there are some irreversible deepening of the voice that can occur if it's not used diligently. But I would encourage you to talk to your fertility specialist about it. It may or may not apply to you. It may or may not be beneficial to you. But some of these treatments that are unlikely to cause any harm may be of benefit, could be included without too much impact. But the guidelines, the professional guidelines suggest that it probably may not have a huge impact on everybody. And I would certainly encourage, if you are looking at adjuvant treatment, to include in your IVF cycle that you have a chat with your fertility specialist. I hope that was Switzerland enough of an answer to answer your question. All right. You know what? I think I'm going to leave it there. Actually, there is one more question. A little bit controversial. I will again try to make this as generic as possible. But I have had somebody ask a question about egg, or rather embryo banking, if you're an older woman and you're thinking about maybe having a second child. Ooh, this is somewhat of an ethical discussion, because certainly most couples that come to see me will come back for a second baby. Because babies are lots of fun, right? And they're part of a life journey. And many people have one and then come back a few years later to have another one. But of course, there's the impact of age, being a couple of years older. So a lot of women are thinking now, a lot of couples now rather, are thinking about creating more embryos to kind of give themselves a bit more of a guarantee later on. And I don't necessarily think that that's a bad thing. There are certainly in Western Australia, there are rules around the creation of excess embryos, and I would certainly discuss this with your fertility specialist if this is something you're thinking about. But different states have different rules about how many embryos that you can actually put away. And it might be that it takes you more than 3 embryo transfers to actually conceive. So it's a really difficult ethical, moral, social discussion that a couple has, both with each other, but also, with their fertility doctor. And it is certainly something, if you are a little older going for your first child, it is something that may come up in conversation, or it may come up in your thinking, that you might want to do a couple of IVF cycles to be able to create enough embryos to give yourself a chance for a second child a couple of years down the track. And I do tend to have this conversation with couples where a woman is over the age of 35, because we do know that once a woman hits 37, her chances of conceiving after that halve each year. And the miscarriage rates go up exponentially. So, it's not an unreasonable thought if you are thinking about the size of your family and what you aspire to be having that discussion with your fertility doctor. So on that very pondering note, I'm going to wrap things up for this week. To those of you who went away for Easter, I hope you had a wonderful time. For many of us, it's back into things again. If you are around a fertility treatment cycle, I wish you all the best. If any of the information from tonight has really inspired you or you found really informative and you think others might find it as valuable, then please don't hesitate to tag them in or share this with them. My whole mission is to empower you with as much knowledge to help you make the decisions that you want around your own fertility journey. So have a beautiful rest of your week. I know I said I was going to have a guest speaker this week. Didn't quite work out, but I think I've got something lined up for next week for you. So have a really beautiful week and I'll keep you in suspense. See you soon.